Hello, I'm Dr. Jung Young-eun. Case discussion. We share the clinical difficulties and find the best solutions. So we have invited 3 masters. Hello. Today's case discussion. Let's look at what issues have been raised by an audience. 55-year-old male, no specific disease. 10 years ago, at 46, mandible implant was placed. Recently, the gingiva bleeds near the implant. Can I keep the implant or should I remove it? Bone is resorbed near the implant, and there is a 3 or 4 millimeter of bone below the implant. The implant doesn't look mobile, but gingiva must have been swelling or bleeding frequently. Even though the treatment is pretty well done, depending on the maintenance or control, things will be different, and implants cannot last forever. Therefore, complications can occur. What do you think? When I treat a peri-implantitis patient, many patients think the implant in this case can be used again. If we consider recurrence and other criteria, if the problem covers more than half of the length of the implant, it is recommended to be removed. If you look at in this case, at one side, bone loss is more than a half of the implant, and the other side is rather ambiguous. If the patient really refuses extraction, I might have to treat it, but I will persuade the patient to remove it and recommend the placement of another implant there. I have a private practice, so I believe it depends on who did that implant placement. Depending on whether it's my case or not, it can be different. If the implant was not placed by myself, I think it should be removed. But the outcome would not be very good, even though we open it and extract it. The implant situation will get worse, and eventually, implant should be placed again. The bone will be resorbed pretty much, and there's a concern about the relation with the mandible. So if it is my case, I would do the curettage. I'm of the similar opinion of these 2 masters. Just looking at the X-ray, the buccal-lingual situation is not clear here. Just looking at the X-ray of that much bone resorption, I guess buccal-lingual bone is also resorbed. Even if we try to regenerate bone and do some recovery treatment, I believe eventually the bone will be resorbed continuously up to the basal bone. I also would recommend removal and placing a new implant there. When a patient comes back with poor outcome, it makes us nervous. I would like to ask our masters to help this questioning dentist. Please share similar cases to explain. Dr. Yang, would you like to go first? Looking at this case, I found a similar case. The site is a little bit different, but we can think about this case. 2007, the patient came to me. At number 16, implant was placed and was followed up and came back. In 2019, the patient complained mobile implant for about a week. On the X-ray, on the other side, compared to before, teeth are lost. On the mandible, we can see the implant placed from somewhere else. The patient must have chewed with the right side due to the heavy load, the screw loosening or something else happened, according to a prosthodontist. Some unexpected thing happened. It is not clearly seen here. If you look at the top of the fixture, the implant is fractured. Regardless of the bone resorption surrounding the implant cannot be recovered because it is structural problem, so it should be removed. So I decided to remove it, and I showed the picture to the patient, and the patient understood. And at that time, OSSTEM launched a tool to remove an implant. The implant is fractured, so I used the kit. In the past, I actually simply removed the implant effectively with that. But in this case, it was not really effective because it is fractured, so EFR kit cannot firmly hold the implant. It was spinning, so it didn't work. I opened the flap. The buccal bone is almost gone. So if you look at the implant, the middle portion is fractured, and the fracture further progressed during removal, so it is removed with an elevator. The implant can be immediately placed, but due to lack of buccal bone, GBR socket preservation was done. What was that? Sorry. Some announcement from my cell phone. Where was I? Sorry about that. So it was removed using an elevator. This is the removed implant. If you take a close look at it, you can see the fracture. You can place an implant immediately, but I used a staged approach. GBR was done first. Resorbable membrane is used to cover the site partially. Is that an open membrane technique? No, it's not. I use a resorbable membrane. I try to close it as much as possible, but not 100% closure was achieved because there was exposed portion of the implant. It was a resorbable membrane, but it is the type that doesn't get resorbed so quickly. I cannot disclose the brand name of the product. It was October 26. This is November 12. So this is 2 weeks later, and it's almost covered. So this is the current situation, and we are waiting. If it gets stabilized buccolingually, I believe we will be able to place an implant. Removing an implant is important, but as Dr. Kim Ki-Seong said, whether we will place an implant again there will depend on who placed the original implant there. If we are thinking about placing an implant again, site development should be done when the implant is removed. Would you go back to the previous slide? This should be removed. So further back. So if we think about why the implant failed, the opposing tooth is missing, so unilateral chewing may be the reason. And the implant is a little bit buccally positioned. If you look at the X-ray, the prosthesis, this is internal connection type implant. What I want to point out is the prosthesis, I don't know whether it's a screw type. I think it is a screw type. The abutment is not CAD-CAM, but UCLA type. I believe this is closely related to the lifespan of an implant. University hospitals love UCLA abutment. There was a paper from Asan Hospital about that abutment too. It said the internal conical connection type implants showed very high screw failures. though it was 4.0, in my view, internal screw type is not very good for passive fit. I don't know whether prosthodontists would agree with me, but I prefer to use OSSTEM's ER type with a screw hole. I don't use UCLA type for long-term stability of an implant. In this case, ER-type prosthesis would have lasted longer. In this case, maybe people think differently. I really hate the screw type using UCLA abutment. So that was about the prosthodontics. The connection type was changed because of the tearing. Do you know, just by looking at it, the brand name of the implant? I don't really do prosthodontics, ready-made abutment and UCLA abutment. So there's a difference in terms of the fit as the cause of that problem. It is related to the screw loosening, which leads to implant fracture later. Dr. Kim Ki-Seong, you gave us very good advice regarding the prosthodontics. Would you introduce some similar cases? Yes, this is my case. Number 16 is like this. So it is removed, extracted. OSSTEM gingival level SS implant was placed. For the single implant, rather than internal conical type, gingival level implant is more stronger, so I use it. When I use this implant, I've seen the failure of osseo integration because of overload, but I have never seen implant fractures. This case, there was bone loss, as I said before. It was my case, so I watched and monitored. So implant fractured. EFR is not appropriate to remove this, so I used a très fine burr to remove it. All the implants are bound to fracture. When cortical bone is resorbed severely, the inflammation can occur, and because of the load, implant would fracture. So it would have been better if it was removed earlier. It is removed using a très fine burr. After the healing, implant is placed again. So I realized all the implants would break. I believe SS implant has the strongest connection, but still it can fracture under heavy load. If it had taken action earlier, it would have been better. So this is my case. The case under discussion is number 46 single case. When bone is lost and the problematic implants, my belief is that it is best to replace it again. So I prefer to explant it and place it again. So this is a case many were explanted. So the patient came to me in August 2017. Full mouth implants were done using various fixtures. Some are from Germany, some the United States, and some local ones. I could see TS3 as well. Surprisingly, one dentist placed all those implants at the same time. The chief complaint is he cannot chew on the left side and the implants are mobile. So how can I treat this? So I thought about removing all of them, but the patient didn't want, so I tried to treat lower anterior first. So the problem was in number 41 and 42, so I cut it. It was useless effort, so one of them is removed. The crown fell off. I didn't have to do it. After removing these two fixtures, the one-body implant could not be placed because there was lack of basal bone, so we decided to wait. After GBR, titanium reinforced membrane, now it is not in the market, and GBR was done and finished. Here the long journey began. The patient came back because the upper anterior just fell off. So we decided to treat upper anterior. We waited 8 weeks later. A little bit of titanium shows, so it is removed and waited. Here is the place. Upper anterior, bone loss, and it fell off like this. Very frustrating. It's opened and implants were just falling off. So one fixture at quadrant 1 remains. We waited for the healing. And the implant in quadrant 1 is removed. So everything was removed. Implant was placed. GBR was done. At one side, the titanium reinforced membrane is used, and the other side, the collagen membrane is used. So it was submerged. 1 week later, panorama X-ray. So I've done up to here. The problem lies in quadrant 3. Here, you'd recognize the brand name of this implant. January 2018. They were removed. There was no basal bone. So when the surfaces are contaminated, I believe chemical or mechanical cleansing, even though basal bone remains up to 2 to 3 threads, there's no way to clean it thoroughly, and epithelialization cannot be achieved, so we decided to expand them. Granulation tissue is removed as well. Bovine collagen block and bovine bone is used for the grafting. It is very inflammatory. If you use autogenous bone or allograft, a lot of it will be resorbed, so hard to resorb materials are used. So if you meet a patient like this, you get exhausted. So it is finished like this. I still don't understand. If you look at quadrant 2, the implant level is quite different. I really wonder. I want to ask the question to the dentist, but I really can't do that, which is very regrettable. CT, February 2018, the second surgery was done. Linear incision technique is used only. So one side is long to remove the membrane. In March 2018, after the delivery of the prosthesis, the screw type, April 2018, quadrant 3 implants were placed with additional grafting. It's very close to the nerve. Yes, as you can see here, it is the incisive nerve in front of the metal nerve. I was surprised when I saw that, but there's no symptoms on the part of the patient. In November 2018, prosthesis SCRP type was delivered. So quadrant 2 remains. At that time, if you look at quadrant 1, it's still usable. Quadrant 2 still remains. 1 just fell off. Here, we need to treat. In this case, EFR kit from OSSTEM is very useful, but it is not appropriate for this. So trephine burr is required here to remove this. This type of fixture, when abutment is connected, once it is almost impossible to remove it. So it's removed and grafting is done. A sandwich technique is used for the grafting. Why did I place implants? The sinusitis is quite serious here. In June 2019, everything is finished. The secondary opening, 3 implants were placed. Did you treat the sinus? No. Because of the implant, sinusitis happened. So if you implant and wait with medication, it automatically subsides. It happens a lot. For upper number 6, because of a lesion, sinusitis occurs, and if you extract and wait, the site would improve. So this is similar to that. CT. The sinus was lifted a little bit using a casket to place implant. In October 2019, at last, it was finished. The patient did not complain about the lower anterior. Is that a cantilever? Yes. It's just a setting. I told him to treat there, but he doesn't want. When he came to me in 2017, 3 years before that, he suffered quite a lot, and he suffered for 2 years since he came to me. So he really loves surgery. So it was completed here. If you look at quadrant 1, it is getting worse. So next time it would be upper anterior or quadrant 1. April 2020, follow-up. He's followed up, but I didn't save the x-ray here, so next time I'll show you. 2 patients appeared almost at the same time with this problem. I have a lot of headache because of it. He is one of them. For in the case discussion, I showed you a patient. I was wondering whether I show him or this patient, but I chose this patient. When there is a periimplantitis, if it is beyond a certain level, beyond the capability of a surgeon, what I want to say in this case is not trying to figure out the reasons. Resolving the issue is more important. Removing the implants is more important. But I don't agree that explanting all of them all together is a good approach. Staged approach is better. So this is a long journey. The journey has not finished yet. So the patient is very lucky to meet you. In another opportunity, I will show you the other patient who has a very similar situation. Let's go to the next case, which is a small case. All leading OSSTEM fixtures are used here. The problem was in quadrant 4 among GS3 products, number 45 and 46. There was severe crystal ball loss, and it was quite spelly. What happened in this case, and what can we do to avoid this? Dr. Kim, Ki-Seong, what would be the reason for this? If you look at it closely, when I deliver lecture at OSSTEM, I'm a prosthodontist, but I made 3 principles in placing implants. The principle 1, when you place an implant, the whole implant should be in bone. As it goes down, it gets more important. The second principle is the top of the implant should be below at least 3 millimeters from gingiva. This is related to biologic width. So this is related to that. The implant is placed too shallow. The most important principle 3 is the fixture top should be 9 millimeters below the antagonist tooth. The most important principle. If necessary, it goes into bone deeper. Internal conical TS implant here, it's the old version is GS implant. It is placed too shallow, so the gingiva cuff of an abutment is low, then this kind of problems occur. This is related to biologic width. I agree. I say this during lecture. You can tell the success or failure of an implant placement. If you use 2 millimeter cuff of an abutment, it will fail. So that's what I say to the class. That's a very simplified generalization. So vertical position errors are made in this case. Dr. Yang? I agree with you. Recently, a paper came out. Dr. Kim Ki-Seong established the 3 principles based on his own long experiences. But you have the evidence in the paper. For example, the shallow positioning or the biologic width can be determined, evaluated based on the gingiva height of an abutment. As you said, 1 millimeter cuff. According to the paper, if you use less than 3 millimeter abutment, bone loss will occur. When we use the one with less than 3 millimeters, that's because of aesthetic reasons. They want the margin of prosthesis to be below or at the gingiva level. Some people have a shallow or deep biologic width, and 3 millimeters of it is not secured. So they had to use 2 millimeters. Conversely, if you use 2 millimeters, bone loss will occur. You know it based on your experience. There's already paper. Conversely, even though it is placed shallow, if abutment is more than 3 millimeters, supragingival margin, bone loss is less. So if you want aesthetic solution, 3 millimeters should be secured. If you can't, the margin should be at higher position. Of course, it's not aesthetic. To avoid it, we need to place deeper. As you said, the first principle, implant surface should be in bone. So that's the point. That's why I brought this case. The vertical position is an issue. Even though I treat here, I thought things would not improve really, so decided to remove the 2 implants. Buccolingual bone level, the bone loss is quite a bit progressed. Abutments are removed here. To remove the sound implants, EFR kit should be used to minimize the bone damage. That's the simplest one. So whenever possible, I use this kit. This is after the removal. The damage is minimal and the flap is opened. To determine the vertical position of an implant, will I put the whole implant in the basal bone, or should I use graft at the top of the implant? That's controversial, but I try to put the whole implant in bone. Even the short ones, yes. Personally, I majored in surgery, but I don't trust myself in building bone. The supporting structures can be surrounded by the graft. However, I try to put the whole implant in bone. That is more reliable. GBR, transmucosal type is used before finish. Fortunately, temporary is using number 4 and 7, CT, post of 3 months, prosthesis, single splint, and single. I wanted 4 singles, but the patient did not like that, so 2 was splinted. You can see there is a big differences in the height, but I thought this would be more predictable. As I said before, I believe you need to explain to whether you are not sure whether you should explant or not. As Dr. Kim Ki-Seong said, there are prosthodontic reasons, but most frequently, this would be the reason for this problem. That's why I presented this case to you. Regarding the case under discussion, do you have anything more to add? One of the reasons to place an implant shallow, we don't trust the short implant. The length should be secured, so that's why 5x6, the short OSSTEM implants are used. I sometimes use them, so I can trust the thick and short implants. So I recommend it to place it deeply. In this case discussion, we talked about the retreatment after implant is placed. Retreatment is always challenging, so we need to be careful from the beginning. I hope this has been very helpful to the questioner dentists. Thank you very much, Dr. Kim, Dr. Yang, and Dr. Son. This concludes the case discussion. I am Dr. Jung Young-eun. I'll see you next time.
수고하셨습니다. 수고하셨습니다.
수고하셨습니다.